Hello everyone, welcome to Nursing Next Live. This is Priyadarshini, your adult health nursing faculty, and we will wait for 5 more minutes. Let some people join before we get into the session. Okay, fine. A very good evening everyone, and as a part of our Plan C Plus English Platinum Edition, we are conducting regular Wednesday and Friday sessions. So this is our Friday session. Again, I have come up with an important high yield topic, and the topic is blood transfusion and their complications. So this is a very important topic, and mostly the questions come from this topic. So here you should be with me throughout this lecture so that you will be having a concept clarity of what are all the important points you have to definitely remember on this particular blood transfusion and its complication before going for any nursing competitive examination, right? So let's get into the session. Very good evening Muva, very good evening Afrin. So as I said you, today we are going to discuss about blood products and its complications. Very high yield important topic. So before going into the session, let me start with a small quote. So it is always seems impossible until it is done. Do you people agree or not? It always seems impossible until it is done. Even sometimes whenever a challenging task comes to me, I feel so anxious, I feel some anxiety, and whether I will be always in a thought process whether I can able to successfully complete it or not. But once I start doing it, I will get a good confidence, and I will go with the flow, and I will complete it in the most effective manner, right? So things are complicated only when you look it from the far. When you make it possible, when you make it work, things become so easy and simple. So competitive examination is challenging, but if you're having a proper strategy, if you're preparing so well, and it is a very easy thing for you, right? So same way, with the same enthusiasm, we are going to get into the session. So here initially we will be learning about all the important topics about blood products, blood and their complications. Then we are going to discuss the MCQs, including image based questions, right? So let's get into the session. So first and foremost, blood and blood products. So who can donate? Who are all the eligible person to donate blood? So first and foremost is the donor should be at the age of should be at the age of 18 to 65 years. The donor should be at the age of 18 to 65 years. The HP of the donor should be never ever less than 12 grams per DL in case of your HP calculation. In case of your hematocrit calculation, it should be never ever less than 36%. Very important points where the questions are asked. First and foremost, in which of the age group is eligible for donating the blood? It is from 18 to 65 years. And which of the HB, like which of the people, what is the HB and what is the lab investigation calculation that has to be monitored before going for blood transfusion is, always remember the HB should be not less than 12%, and in the same way just remember about the hematocrit. The hematocrit should not be less than 36%. Next, the blood collection about the donors. According to the weight, we are collecting the bloods in the ml, right? First, if the weight of the individual is 45 to 50 gram, if the weight of the individual is 45 to 50 gram, we are going to collect only 350 ml of blood from that particular donor. Okay, so if the weight of the patient is, if the weight of the donor is 35 to 55 kg, we are going to collect only 350 ml of blood from that particular donor. If the weight of the individual is more than 55 kg, is more than 55 kg. This is greater than symbol, okay? This is greater than symbol. If it is more than 55 kg, you are going to collect 450 ml of blood. 450 ml of blood. So weight calculation, age calculation, and your lab investigations, which is most commonly asked in your examination. So you have to note it definitely. For a healthy individual whose weight is more than 55 kg, we are going to collect 450 ml of blood. So then the systolic blood pressure. The systolic blood pressure always should be between 100 to 160 mm per mercury. And when we are talking about the diastolic blood pressure, it should be always 60 to 90 mm per mercury when we are collecting the blood from the particular donor. So as you all know, the important nursing implication is also to remember that you have to monitor all these basic parameters which is coming under the nursing responsibility. So next, always the heart rate should be 60 to 100 beats per minute. So what is the donation interval? This is also one of the most common questions which is asked. What is the donation interval? Like how can, once I donated, within how much time I can donate again? What is the interval between one donation to the other donation? Okay, and we have certain active members in the society where they give recurrent, they do recurrent blood donations. So as a healthcare professional, it is very important to know what is the interval between one blood donation to the other blood donation. It is always 12 weeks. There should be a 12-week gap between one blood donation to the other blood donation. There should be a 12-week gap between one blood donation to the other blood donation. And what is it in months? If you tell, it is 3 months, right? It is 3 months. So next, the blood should be placed at 4 to 6 degree immediately after the collection. So once the blood is collected, it has to be stored appropriately under 4 to 6 degree based upon the material you collect, and it has to be placed in the 4 to 6 degree immediately after the collection. So next we have the additives. One of the most important points you have to note is the additives. So what is the use of additives? Why we need to add additives in the blood bag? So first and foremost thing is to increase the shelf life of the blood. Okay, to increase the shelf life of the blood, we are going to use these additives to preserve the blood properly for the transfusion, right? Once it is collected from the donor, it is put into the bag, and these are the additives which is added inside the bag. It is very, very important to know. So first is the CDPA. What is the expansion of CDPA? What is the expansion of CDPA? CDPA, C stands for citrate. You have to remember, citrate is very, very important to note. Okay, citrate is very, very important to note because citrate toxicity, citrate related metabolism errors, citrate related metabolical changes and electrolyte changes are very common. So it is very important to know about citrate. So citrate act as an anticoagulant. The people you can get the question like, what is the role of citrate in the blood bag? Right. In CDPA, C stands for citrate, P stands for phosphate. P stands for phosphate, and D stands for dextrose, and which act as an energy, in the product. And A stands for adenosine, which is also again acting as an ATP, and that is in the energy form. So first and foremost, CDPA is citrate, phosphate, dextrose, and adenosine. So this citrate is acting as an anticoagulant, and citrate is very important component to note also because citrate mechanism is involved in the electrolyte imbalance and in case of ABG changes also. So it is very important to know, which we are going to discuss in detail in further class. So P stands for phosphate, and D stands for dextrose, and A stands for adenosine. So here where the question comes, what is the shelf life? What is the shelf life if an additive CDPA is asked? If CDPA is added to the blood bag, the shelf life of the blood is 35 days. Okay, 35 days is the shelf life of the blood, right? So this is the question they might be asking. And which is the most common additive which is used in blood transfusion? If the question is there, so that is the answer is your CDPA only. Next we have the SAGM. SAGM, S stands for saline, A stands for again same adenosine, just remember. G stands for glucose. Both, as the name implies, adenosine and glucose will be acting as an energy component for the blood. And M stands for mannitol. Remember, M stands for mannitol. So why we are using mannitol? In order to decrease the hemolysis. So hemolysis is one of the biggest Hemolysis is one of the biggest complication, which is most common complication, which is arising after transfusion, right, in the transfusion reaction part. So mannitol is one of the component which is used to decrease the hemolysis, right. So what is the shelf life of sagum? Sagam's shelf life is 42 days. Always remember, the CDPA shelf life is 35 days and the sagam's shelf life is 42 days. And what is the expansion of sagum? Just remember, it is saline, adenosine, glucose and mannitol. If at all they are asking what is the role of mannitol in the blood bank, in the blood bag, so you have to remember it reduces the hemolysis. It reduces the hemolysis. Very good evening, my dear children, very good evening. So next we have the ACD, which was used in previous time. Whether now it is in practice, now maybe it is in practice or not. Okay. So A stands for adenosine, C stands for citrate and D stands for dextrose. So as you all know, what is the role of citrate? Role of citrate is anticoagulation. It acts as an anticoagulant. What is the role of adenosine? What is the role of adenosine? It is also an energy component. And again, dextrose is also going to give the energy component only. And again, where the question will come, the shelf life. What is the shelf life of ACD? The shelf life of ACD is 21 days. The most important component which you have to understand is the expansion of the component, and the shelf life is where the question can come. The shelf life is 30 days for CDPA, the shelf life is 42 days for sagum, and the shelf life for ACD is 21 days. Very, very important to remember. So next we are going, once we collected the blood, everything, the donor is very good and he is capable for donating a blood, and we have collected the blood, the proper storage is done. So next, what is the step? Once this is done, we have to go for ABO incompatibility. We have to do blood grouping, ABO incompatibility to that particular blood product, right? So this is very important, and in most of the cases questions come from this particular image. In last NORCET also this was been asked, so it is very important to know. As we know, we have group A, B and AB. So before that, I would like to clear what is ABO compatibility. So we are going to do blood grouping for the patient first. Okay. We are going to do blood grouping for the patient. Okay. Then we are doing ABO compatibility, right? So in this, the most common questions which is asked is, which of the chromosome is involved in this ABO? Which of the chromosome is involved in this ABO? When they are asking which of the chromosome or gene which is involved in ABO is, it is chromosome 9q. Very, very important to note, it is chromosome 9q. Chromosome 9q. What is the genetic inheritance of this ABO? What is the genetic inheritance? What is the genetic inheritance of this ABO? Any idea? Anyone can tell me what is the genetic inheritance behind this ABO? What is the genetic inheritance behind this ABO? It is codominance. It is codominance. And one of the another important point which you have to notice, all this A, B, O, AB, so everything has this antigens, their respective antigens. These antigens are generated by the gene H. This gene H. So all these particular particles, all these particular blood groups will be having gene H, that is anti-H is present in all these blood groups. Anti-H is present in all these blood groups. Just remember this thing. So next we are coming back to this blood group charting. So first you know the group A people, what group A people will be having. The group A people will be having the antigen in the surface area of the RBC. As you all know, this is the RBC, and in the surface area of the RBC, A antigen is present. Okay, that's why they are termed as group A. So in the serum, in the plasma, they will be having the antibodies of B. That's why we cannot transfuse B group to this particular A group people, because these antibodies will create a cross reaction and create a chaos. Right. So just remember, on the surface area, like what is the antigen present on the surface area of the RBC is determined the group. It is determining the group. So in group A people, the RBC surface area will be having the antigen A. Antigen A. So what is the antibodies which is circulating inside the plasma or inside the serum? That is anti-B. The same component is repeated to group B also. In group B, as you all know, in group B, the antigen which is present in the surface area of the group B's patients, group B blood group will be anti-B. Sorry, antigen B. So next, what is the particular component which is present in the plasma? In the serum and plasma, the patient will be having anti-A antibodies. Anti-A antibodies. So that's why if you're going to transfuse A blood group to A positive blood to B patients, what will happen? This is going to create an antibody reaction, right? So that is the component. So what is present in the B group blood group's RBC surface area? It is B antigen. You have to remember this. Then in group AB, when the patient is a case of group AB, when a donor is a case of group AB, what is happening? The surface area is going to have the both A and B antigens. The surface area is going to have both A and B antigens, and you have to remember the most important thing, there will be no antibodies. There will be no antibodies in case of AB blood group. That's why your AB blood group is known as an universal recipient. Okay? Universal recipient. Okay? Universal recipient. Okay. So next we have the group O. In group O, in this here, there will be no antigens which is present in the surface area of the RBC. There will be no antigens which is present in the surface area of the RBC. Topic is blood transfusion and blood products. Blood products and its complication here. So group O, in group O what is happening? The antigen which is present in the surface area is nil. But there is an obligation which you have to remember. As I talked about H gene, as I was talking about H gene, H antigen, anti-H is present in A group, anti-H is present in B group, anti-H is present in AB group also, anti-H is present in O group also, right? So, but you have to see about the antibodies in the plasma. So, here you have anti-A and anti-B antibodies are present inside the O group patient. Okay, that's why we cannot transfuse this AB blood group to this patients. So next we have the Bombay blood group. Bombay blood group is one of the most rare blood group. When they ask you a question, what is the most common blood group? The most common blood group in India is, any answers? Most common blood group. Very good, Ritvik. Just tell me, what is the most common blood group in India? The most common blood group in India is O positive. Okay, on the other hand, when you talk about the least common is your OH negative, that is your Bombay blood group. OH negative, that is your Bombay blood group. OH negative, that is your Bombay blood group. Okay, that is your Bombay blood group. Remember? Yes, O positive is the correct answer. Right? So next we are going to learn about what is this Bombay. Do not break our head. We are going to explore what is Bombay blood group now. Okay? So what is Bombay blood group? As I said you, the first MCQ point, the least common blood groups in India is the Bombay blood group. Right? So it is a rare form of blood group as we have discussed earlier, and no antigen present on the surface area of the RBC. No antigen is present. Remember, it is not antibody. It is talking like there is no antigen which is present on the surface area of the RBC, right? No antigen is present on the surface area of the RBC, which includes there is no A, there is no B, there is no H antigen also. The H antigen which is present in all the blood groups except your Bombay blood group, right? Except your Bombay blood group. Now, but in the serum, anti-A, anti-B and anti-H. So that's why antigens, no antigen is present on the surface area of the RBC. Okay, which means it is not going to accept any other bloods, first and foremost point. But in the serum, it is again having anti-A, anti-B and anti-H, which means whenever you are going to administer any kind of blood, these kind of antibodies is going to cross, these kind of antibodies is going to give a very, very bad reaction to that particular blood. So it is not possible to apply, it is not possible to transfuse any of the blood components in case of Bombay blood group. Okay. Can't be transfused to any other blood group. It cannot be transfused to any other blood group. Very, very important point to note. It cannot be transfused to any other blood group. Even O has anti-H. As I said you, anti-H is present in A, AB, B and O. So even O has anti-H, so O is also not applicable for transfusing with the Bombay blood group. So this Bombay blood group patients is very rare. Okay, this blood, when it is collected, it is kept for 10 years in the blood bank. This is kept for 10 years in the blood bank. And the most component thing where the questions will be asked is, what is used to store this? So we are using, okay, this is the question point, 5% DMSO, that is your dimethyl sulfur oxide. So this is used, this Bombay blood group is used to store for 10 years with the help of this 5% DMSO. What is the expansion of DMSO? It is your dimethyl sulfur oxide. Okay, dimethyl sulfur oxide. So here again the question point here, like most of the questions come here. So high yield point. So the universal donor of PRBC, packed red blood cell, the universal donor of PRBC is O negative. The universal donor of PRBC is O negative. Very good, Ritvik. So the universal donor of fresh frozen plasma is AB. When they are asking, just remember first thing, the universal donor of PRBC is O negative and the universal donor of FFP, the universal donor of FFP, excuse me, sorry, the universal donor of FFP is AB. So if at all they are asking you very specifically, okay, most preferred, if most preferred was in the question, then you are going to answer the universal donor of FFP is AB negative followed by AB positive. Okay, just remember this. If they are asking the question for universal donor for PRBC, it is O negative. If they are asking the universal donor for FFP, you are going to answer AB. If AB, if they are more specific, and if AB negative and AB positive is there in the option, you are going to take AB negative. You are going to take AB negative because that is the most possible correct answer. So next, so the blood transfusion is tested for what are all the thing. Okay, so the disease which is tested in India is your HIV, HBV, HCV, hepatitis A, malaria, syphilis, your cytomegalovirus and your Epstein-Barr virus. So Epstein-Barr virus is rarely transmitted through blood transfusion. If you have a question like, if you have a question, which of the following disease has highest incidence, okay, sorry, least incidence, we can keep least incidence. Which of the following disease is having the least incidence during blood transfusion? Option A is HIV, option B is HCV, Option C is hepatitis A, and option D is Epstein-Barr virus. So now answer me which is the correct answer. Now answer me which is the correct answer. Which of the following disease has the least incidence during blood transfusion? Okay, during blood transfusion in India, if you have the question. So now you tell me either option A, HIV, HCV, or hepatitis A, or Epstein-Barr virus is the answer. Now tell me, what is the correct answer? A. No. See, listen. As I have listed and said you, like HIV, hepatitis B virus, HCV, hepatitis A, malaria, syphilis, everything is monitored. The least common, the rarely transmitted is Epstein-Barr virus. When Epstein-Barr is there, definitely you have to go and take this is the correct answer. Very good. Many people are answering correct. Very good, very good, very good. So, this is the correct answer. So please put your, dear children, please put your comments in English so that I can answer you so effectively. Because मुझे है ना हिंदी थोड़ा थोड़ा आती है, ज़्यादा नहीं आती है. ठीक है? Okay. So now the storage lesions. So first is when we are storing the RBC, okay, for a longer period of time. Very good. Many people are answering correctly. Very good. So when you are storing the RBC, okay, your PRBC or whatever blood components for a longer period of time. So what are all the reactions which is happening? First in turn, it is going to reduce the ATP level and it is going to reduce the 2,3 DPG level. So 2,3 DPG level is very, very important to note. Okay, when the blood is stored for a longer period of time, it is going to reduce its ATP level, energy level, and followed by the 2, DPG level, which is involved in hemoglobin association. Okay, so what happens here is this DPG level is involved in the affinity of the oxygen. So if the DPG level is going to decrease, it is going to cause increased affinity towards O2. It causes increased affinity towards O2 so that the circulatory blood, okay, it is going to have lot of affinity towards O2 so that the absorption of O2 in the systemic circulation is reduced. Right. So if they are asking a question, when there is a longer period of storage time for a blood, what is, if the DPG level is reducing because of it, so what is the oxygen dissociative curve? How the oxygen dissociative curve is looking? So always remember the oxygen dissociative curve is shifts towards left. It shifts towards left. It shifts towards left when there is a DPG level declination. Okay, it shifts towards left when the DPG level is decreased. Okay. Okay. So next, the pH of the blood will become acidic. The pH of the blood will become acidic. Next, this citrate, as I said you, citrate is, what is the action of citrate? Basically, citrate will be binding to calcium. Okay. If you talk about citrate, citrate binds to calcium to reduce the coagulation. Okay, to reduce the coagulation and clotting. Okay, so here, if it is going to chelate, if the citrate is going to be more higher and if it is going to chelate more calcium, this in turn, when it is administered to the patient, this in turn going to cause hypocalcemia. Hypocalcemia. Just remember this, a very, very important point. Okay, very, very important point to note. Citrate is, in normal, citrate binds to the calcium in order to reduce the clotting and coagulation. So here, when you're going to administer this to the patient, and like in case of massive transfusion, if we are doing, in this case what happened, this citrate will chelate to the calcium, which causes more binding towards the calcium, and which in turn going to cause hypocalcemia. On the other term, this citrate is metabolized in the liver. Okay. On the other term, okay, on the other instant, the citrate is going to be metabolized in the liver. Metabolized in liver. So when this is metabolized in liver, it is going to release lot of bicarbonates, which in turn going to cause metabolic alkalosis. Metabolic alkalosis. Very, very important MCQ point these things are. So you have to remember. When the patient is going for metabolic alkalosis, what is the, am I audible? Am I audible? Please tell me, am I audible or not? Please put a message in the comment box. Very important. Am I audible? Yes, yes, okay, fine. So when the patient, when the citrate is metabolized, it is metabolized in the liver, which in turn is going to cause metabolic alkalosis. So this in turn going to cause hypokalemia. Hypokalemia. But we also have hyperkalemia in blood transfusion. Okay, hyperkalemia storage lesion also is there, because whenever there is a lysis of RBC, it is going to lead to hyperkalemia. Whenever there is a lysis of RBC, when hemolysis, sorry, when hemolysis is taking place, when hemolysis is going to take place, in such conditions, the patient will go for hyperkalemia, because lot of RBC, in the RBC, potassium is stored in greater extent. So when there is a breakdown of RBC, that is what we term as hemolysis. When there is a very much background of RBCs, this potassium which is stored inside the RBCs is going to move, and it is going to cause hyperkalemia. So in this state, because of the storage, okay, because of the extensive number of storage, so here the patient is going to get hypocalcemia. Very, very important. Hypocalcemia, it is because of the citrate, because of the chelation of calcium, chelation of the calcium, it is going to lead to hypocalcemia. On the other hand, what is the another mechanism? This citrate is going to be metabolized in the liver. It is going to metabolize in the liver. This in turn going to cause an ABG abnormality, that is metabolic alkalosis, and followed by this metabolic alkalosis will lead to hypokalemia. So again, coming back to the lysis of the RBC, lysis of RBC will lead to hyperkalemia because of excessive number of RBC, so excessive number of potassium is stored inside the RBC. When there is an extensive breakdown, this in turn going to cause hyperkalemia. So hypokalemia, why we have seen. Next, in platelets, platelet storage lesions. For longer period of time, platelet storage, what will happen? It leads to loss of discoid shape in the RBC. It will lead to loss of discoid shape in the RBC, and it causes microscopic platelet aggregates. It causes microscopic platelet aggregates. Okay? So here you have to remember, in RBC there will be decrease in ATP and decrease in 2,3 DPG level, which in turn going to cause the oxygen dissociative curve to shift towards the left side. You have to remember this thing because it is a very, very important MCQ point. What is the pH of that particular blood? It is going to be acidic because of the citrate. First and foremost, what is happening? Because of the citrate, chelation of the calcium is going to happen, which in turn going to cause hypocalcemia. On the other hand, citrate is going to be metabolized in the liver, which in turn going to cause metabolic alkalosis, followed by the patient is going to get hypokalemia. And what is the mechanism with hyperkalemia? It is because of the lysis of the RBC. So in case of specific to platelets, you have to remember loss of discoid shape in the RBC will be seen, and microscopic platelet aggregations will be seen. Okay, very good, Geeta. So next is we are going to see like how the blood is differentiated into different parts. Okay, how it is differentiated into different parts. So once we collect the blood as a whole blood from the patient, okay, we collect the blood as a whole blood from the patient, and we will be doing a centrifuging. We will be doing centrifuging, and you will be separating blood into these three components. First, the lower level, that is your PRBC. Okay, next there is a buffy coat, that is the leukocytes. This is the buffy coat. Okay, buffy coat, that is leukocyte layer will be there, and followed by in the upper part of the specimen, you can see platelet rich plasma. You can see platelet rich plasma. So this PRBC, again this PRBC plus this leukocytes, this will be done for leukoreduction. Okay, leukoreduction, where again this will be separated. Okay, it will be separating PRBC to your, this will be separating the PRBC from the leukocytes. Okay, soft centrifugation, centrifuging is happening, and this the whole blood, this buffy coat with the PRBC will be done with the leukoreduction. So this in turn going to give you only the PRBC. Okay, very good Komal, very good Komal. So this in turn going to give you the PRBC. Okay. Again we are going to talk about this platelet rich plasma now. Okay, now we have the platelet rich plasma. So this platelet rich plasma, again it will be going for centrifuging, and it will be converted into platelet poor plasma. Okay, platelet poor plasma. Okay, just tell me in what types it will be, in what type it will be bifurcated when it is centrifuged. It will be the PRC, that is the platelet rich plasma. The platelet rich plasma will be again centrifuged, and it will be divided to platelet poor plasma and the plasma concentrate. And again you have to remember, this platelet poor plasma will be again involved in getting your FFP, that is your fresh frozen plasma. Then FFP only we are getting this cryoprecipitate. Again important MCQ points are there in this, we will see in the next slide. So first is your FFP, your fresh plasma protein. Okay, your fresh plasma protein should be separated from the whole blood within 6 to 8 hours, not later than 6 to 8 hours. FFP has to be separated from that poor plasma protein. Okay, poor plasma concentrate. As I said, you poor, like platelet poor plasma. Okay, FFP is derived from the platelet poor plasma. So this particular component of separation has to be done within 6 to 8 hours of the collection, and it should be frozen solid in the -30°C or lower. Very, very important point to note. Okay, so first and foremost thing, your FFP is derived from the platelet poor plasma, which has been derived from the plasma which is segregated on the top side of the leukocyte and the RBC, right? So here you have to remember just one thing. From the platelet poor plasma only we are deriving FFP. From the FFP only we are deriving cryoprecipitate. So here you have to remember, the fresh plasma protein should be separated from the whole blood within 6 to 8 hours, and it has to be frozen solid in the -30°C or lower than that. Next we have, once it is thawed, as you all know what is meant by thawing. Thawing is like these, as we said, it will be freezed. It will be freezed and it will be frozen. So before it is administered to the patient, obviously it has to be thawed, which means it has to be converted into liquid form so that it will be administered to the patient effectively, right? So that is called thawing, like making that solid frozen FFP into a liquid form in order to making it compatible for administration to the patient. So that is called as thawing, right? So once this thawing is done, it should be administered within 6 hours. This is a very, 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 very important point. Okay, this is very, 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 very important point. You have to definitely note this for any competitive examinations. So once the fresh frozen plasma is thawed, within how much time it has to be administered? If there is an MCQ, you are going to close your eyes and you are going to answer it is 6 hours. Within 6 hours, if the FFP is thawed, it has to be administered to the patient. Very, very important point to note. So cryoprecipitate, as I said, cryoprecipitate is obtained from your FFP. Cryoprecipitate is obtained from the FFP. Now, where again they are going to ask you question is, if you are talking about FFP, what are all the particles, what are all the components which is present in the FFP? FFP has all coagulation factors. Again, very, very important. What is the component present in FFP? If there is an MCQ, you are going to go and click. All coagulation factors is present in FFP. When they are going to specifically ask, what are all the particles, what are all the components? Excuse me. What are all the components which is specifically present in the cryoprecipitate? So it is your factor 8 von Willebrand factor and your factor 13 and fibrinogen. Remember, FFP is having all clotting factors. FFP is having all clotting factors because based upon that only the indication will be decided. Okay, in case the patient is having a von Willebrand factor deficiency, so we are going to administer cryoprecipitate to that particular patient. So based upon the need, you have to administer. So that's why the composition is very important. So if you learn about FFP, in FFP all the clotting factors is present, all the coagulation factors is present. In case of cryoprecipitate, it is very selective, and it is very, very important question point also to note, that is factor 8 von Willebrand factor, your factor 13 and fibrinogen is present in your cryoprecipitate. Okay, so next we are going, yes, very good evening dear. So this is again an important slide, a very, 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 very important slide. So first is packed RBC. PRBC is stored in 1 to 6 degrees Celsius. Okay, typically 4 degrees Celsius plus or minus to 2 degrees Celsius. PRBC, packed RBC, is stored in 1 to 6 degrees Celsius. So the shelf life is always depending upon the anticoagulants which is used. For example, if you see 35 to 42 days. What is 35 days? Shelf life of 35 days is seen in CDPA. Very good. Okay, shelf life of PRBC, when it is 35 days, so what anticoagulant it is used? It is CDPA. If it is 42 days, it is SAGM. So what is the compatibility requirement before administration of the PRBC? The compatibilities which is required before administration of the PRBC is, you have to do ABO and RH compatibility. So we missed RH again, RH compatibility. So in RH we are going to analyze for the D antigen. If the D antigen is present, we are going to tell it is positive. It is absent, we are going to tell it is a negative component. Right. So next we have the whole blood. Whole blood has to be stored in 1 to 6 degree, that is 4 degree to plus or minus 2 degrees Celsius, and the whole blood 35 days CDPA is used. The most common additive which is used to increase the shelf life is CDPA, and here both ABO and RH incompatibility we are checking. Next is FFP. FFP should be stored in less than or equal to minus 30 degrees Celsius, and it should be frozen, and it can be given for, the shelf life is 1 year. And now tell me, if it is thawed, within how much time it has to be used? Now you have to tell me, if it is thawed, within how much time it can be used? Can you please tell to switch on the AC and water for me? Yes. Now tell me, cryoprecipitate, if it is thawed, within how much time it has to be? Yes. 6 hours is the correct answer. 6 to 8 hours. No. As per the all important book references, it is 6 hours. Okay, within 6 hours you have to definitely administer the FFP once it is thawed. But the shelf life is up to 1 year. Okay, once it is thawed, you have to use it within 6 hours. Okay, so ABO compatibility is required, RH is not required. Next we have cryoprecipitate. Cryoprecipitate is also stored in the same temperature, less than or equal to minus 30 degrees Celsius, and its shelf life is also 1 year. After thawing, it also has to be used for before 6 hours only. Okay, before 6 hours only, and can be transfused to any ABO group. It can be transfused to any ABO group. Okay, it can be transfused to any ABO group, and RH is not considered relevant for this. Next is platelet concentrates. In platelet, 22 to 24 degree, and platelet is the one which is stored in the room temperature. Platelet is the one which is stored in the room temperature, and this one is having the highest risk for bacterial contamination. Having the highest risk of bacterial contamination. So very good handling is required in case of platelets, and the blood bank should have a very good policy and protocol to maintain this adequacy, right? So platelet is the one which is placed in the room temperature at 22 to 24 degrees Celsius, and the shelf life is 3 to 5 days. Right, and preferably ABO and RHT compatibility can be done. In case of emergency situation, ABO and RHT group is not required, and random donor platelet also can be administered. Okay, a very, very important table. So now, what is the protocol for blood transfusion? Okay, first, this is very easy for you people, so it will be a quick review now. So transfusion started within 30 minutes once you procure the blood from the blood bank, as you all very clear. Next, must complete within 4 hours. The blood which is transfused, once you start the transfusion, it has to be completed within 4 hours. Next, the patient observation for the first 15 minutes, and then for every 1 hour you will be doing. But based upon the hospital policies and protocols, this may be varying. But for the first 15 minutes, you're going to make the drip rate very much less, and you're going to analyze the patient is having any initial reactions or not, where the nurses play a very important role. Okay, then once completed, observe for the next 4 hours. Once completed, you have to observe the patient for the next 4 hours for any transfusion related reactions. So next is what is the impact of after administration of the PRBC? Okay, so if you are administering the PRBC, your HP is going to increase by 1 gram per DL. It is going to increase per 1 gram per DL if you are going to administer 1 unit PRBC. And same you have to remember for HCT also, it should be increasing by 3%. So when you have to analyze this report has to be generated after 4 hours only. This has to be monitored after 4 hours only, so that you can see this visible laboratory changes in the blood. Okay. So next we have the platelet. The platelet has to be started immediately. Once it is received, it has to be started immediately. In most of the cases, which of the particular component is administered first? Okay, either some of the condition, like in case the patient is having hypoxia, acidosis, and the patient is going for massive blood transfusion. In those cases, what we are going to do? In those cases, we are going to administer the PRBC first. PRBC, then your FFB, and followed by your platelet. But in this case, like in general perspective, if the patient, we got the platelet first, it has to be started immediately. Okay? It has to be started immediately. Okay, and now complete it within 20 to 30 minutes. So for PRBC, it is 4 hours. You have to complete within 4 hours. In case of platelet, you have to complete it within 20 to 30 minutes. Thoda in the see my dear Dhiren, this particular class is for exclusive for Plan C plus students with English audience, and this has to be understood by all the people. So that's why I'm speaking in English, and I will be very slow so that you'll be getting clearly. Okay, don't worry, you will be understanding things. Okay, I'll be quite slow for you so that you can able to understand it easily. So first, as we discussed earlier, for platelet you have to administer within 4 hours. For a PRBC, you have to administer within 4 hours. For platelet, you have to start it immediately, and you have to complete it within 20 to 30 minutes. So here also you have 2 important components, that is your random donor platelet and your single donor platelet. What is meant by random donor platelet? You are mixing and compiling 5 to 6 donor platelets. you're mixing and compiling 5 to 6, you're collecting the platelet from 5 to 6 donors and you're compiling it, and this is going to increase 5,000 to 7,000, okay, per transfusion. Okay, per transfusion your platelet count is going to increase for 5,000 to 7,000 in case of your random donor platelet. Again, you're coming back to the single donor platelet. Single donor platelet, as the name implies, it is going to have the donor from only one person. It is not having multiple person. But how we are doing this process? We are doing the process by means of apheresis. What is meant by apheresis? So what we will do, I will attach the cannula, whatever component I need from the patient. For example, here I need only the platelet of the patient. So what happened? The blood will be coming out, it will be coming as a whole blood, and we will be only collecting the platelet and storing it, and the rest of the rest PRBCs, leukocytes, WBCs, everything will be sent back to the patient through that particular mission. So that process is termed as apheresis, the process in which the blood which is required, the particular blood which is required is collected from the patient, and the rest of the blood components will be transfused again back to the patient. That is termed as apheresis. Clear about apheresis? So what is apheresis? Harvesting the particular component and returning the rest of the blood to the donor. So you have to remember which is the question point here. In case of random donor platelet, the question is, it is going to increase the platelet rate by 5,000 to 7,000, okay, per bag. In case it is a single donor platelet, you have to remember it is going to increase the platelet rate by 30,000 to 50,000 per bag. It is going to increase the platelet count by 30,000 to 50,000 per bag. So here we are using jumbo bag, big bags. Okay, so that is why it is increasing the platelet count by 30,000 to 50,000 per bag. So again, transfused within 24 hours after thawed and stored at 1 to 6 degrees Celsius. Okay, this is transfused within 24 hours after it is thawed, and it has to be stored at 1 to 6 degrees Celsius. So next we have FFP. Ideally it is started immediately and can be given up to 6 hours after thawing, right? Ideally it also has to be started immediately, and what you have to do, what you have to think is, it can be given up to 6 hours after it is thawed. So completed within 20 to 30 minutes again. So cryoprecipitate thawed at 37 degrees Celsius and should be used immediately. So cryoprecipitate is also working on the same mechanism, right? Yes. Yes. Here we are coming for the most important topics which you are going to see. All the basic and general concepts which we have discussed are very important for your examination. All the key points and question points has been mentioned by me. Have a quick review of those particular points before going for the examination. So now we are going to see about transfusion reactions. So what are the types of transfusion reaction? We have immune mediated and non-immune mediated. So generally we have our anaphylactic reaction, acute hemolytic reaction, febrile non-hemolytic reaction, urticarial reaction, transfusion related acute lung injury where the questions come, and delayed hemolytic reaction, transfusion associated circulatory overload where the question is coming, transfusion transmitted bacterial infection, which is very common in platelet transfusion, and graft versus host reaction. So here just remember one thing, dear children. Here we are going to see what is the key point, and you are going to be with me so that you are going to remember everything, and while practicing the MCQs you will be crystal clear, like if this are the possible symptoms which is seen in the patient, this is the answer, this is the reaction which has happened. So just concentrate on the key points which I am telling. Just open your ears so widely and get ready. First is anaphylactic reaction. Anaphylactic reaction, what is the cause of anaphylactic reaction? First and foremost, you have to remember anti-IgA antibodies. So very commonly you can tell IgA deficiency when the patient is a very much immunocompromised patient. When the patient is very much immunocompromised and he is having IgA deficiency. So some sensitization mechanism will be happening in that patient's body, and it will cause anti-IgA antibodies. Okay, already the patient is in the deficiency. Because of some sensitization and the reactions, what happened? The patient is going to develop anti-IgA antibody. So because of this anti-IgA antibody in the immunocompromised patient, anaphylactic reactions can possibly occur. This onset is within seconds to minutes. Just you have to remember this point, very, 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 very important point. So anaphylactic reactions will be shown in the patients within seconds to minutes. And what is the cause of this particular anaphylactic reaction? Just remember IgA deficiency. Because of IgA deficiency, the patient body is sensitized towards IgA deficiency, and they are producing anti-IgA antibodies. So that's how this particular patient is getting the anaphylactic reaction. Just remember one key point: anaphylactic reaction, A. A stands for IgA. IgA deficiency. IgA deficiency. Right? Just remember this thing. So next is, what is the onset? What is the duration? Because in MCQs you will be having this duration only. So the duration is, it happens within seconds to minutes. This anaphylactic reactions is going to happen within seconds to minutes. So next, the clinical features. The patient is going to have angioedema. Angioedema means what? The major organs will, the major tissues will be getting so much edema. You can see facial flushingness, puffiness and all. That is termed as angioedema. The patient is going for hypotension, respiratory distress or wheezing, shock and heaves. Heaves is otherwise known as urticaria. That is itching sensation, right? So anaphylactic, what is the treatment for anaphylactic reaction? If the patient is having anaphylactic reaction, you're going to you have to cessate the transfusion. You have to stop transfusion immediately. Then you're going to administer epinephrine, and you're going to administer antihistamine and oxygen and fluids and vasopressors. See, everything is based on, like, you will be stopping it and you're going to immediately report to the physician, and he will be generating the orders, like what is the next step for that particular patient, right? So administering epinephrine, antihistamines, oxygen and fluids and vasopressors if it is required and if it is instructed by the physician. So next, this is about an anaphylactic reaction. Always anaphylactic reaction, keep in your mind, it is IgA deficiency. IgA deficiency. Next, we are coming back to urticarial reaction. As I said, urticarial means what? It is itching type of sensation. So this causes of urticarial reaction is preferred by the recipient's IgE antibody. So remember, anaphylactic is because of IgA and urticaria is because of IgE. It is because of IgE antibodies against the blood products and components. And if the patient's blood is if the donor's blood is going to have soluble allergens in the donated plasma, so that is going to cause this urticarial reaction because of the interaction with the IgE antibodies. So the onset is 2 to 3 hours. Remember, there in anaphylactic reactions, the onset is within seconds to minutes. Here the onset is of 2 to 3 hours. So what are all the findings you have? The patient will be having heaves and hitching. So urticarial reaction treatment: immediate cessation of the transfusion, administer antihistamines as per the physician order, then we can resume the transfusion if the patient is otherwise asymptomatic. Next, we are coming back to the most important part, which you have to definitely remember and learn. First is acute hemolytic reaction. Acute hemolytic reaction. Whenever you see a word, acute hemolytic reaction, which means there is an lysis of RBC and the RBC is involved. So that is termed as hemolytic reaction. So acute, in case of blood transfusion, if you see a word that is acute, acute means within 24 hours. Within 24 hours, if it is happening, that is termed as acute. If it is happening more than 24 hours, you're going to tell it chronic. Right? So in acute, the causes of acute hemolytic reaction is ABO, incompatibility. Whenever we are misidentifying the patient, we are not performing the cross matching properly, okay, improper labeling, this will lead to acute hemolytic reaction. Remember, acute hemolytic transfusion reaction, what is the cause? First and foremost, you have to close your eyes and you're going to take ABO, incompatibility. You're going to take ABO, incompatibility. ABO incompatibility. So the most common reason for this is clerical error, like patient misidentification, improper labeling, and these are the reasons where you can get this acute hemolytic reactions. And the onset of this reaction is within 1 hour. Within 1 hour. Very, very important point. The two important points you have to remember in acute hemolytic reaction is, first, what is the cause? The cause is ABO incompatibility. The cause is ABO incompatibility. The cause is ABO incompatibility. And what is the duration when it is occurring? The duration is it occurs within 1 hour. The duration is it occurs within 1 hour. So next, what are all the clinical features? The patient will be having fever, chills, hypotension. See, you have to remember, like each and every hemolytic reactions, each and every blood transfusion reaction is going to have a similar pattern of just clinical features. So what you have to do, you have to read the question properly. You have to find for keywords. Like we have the causes listed. We have the duration at which it occurs. It is acute or it is chronic, within how much time it is happening. So these keywords will guide you to go to the correct answer, and also to reduce the misleadings, right? So fever, chills, hypotension, hemoglobinuria. Hemoglobinuria because of the lysis of RBC, there is a sedimentations of RBC in your urine. And flank pain, the patient will be having flank pain because of the crust formation in your kidney, and the patient will be having disseminated intravascular coagulopathy. What is meant by disseminated intravascular coagulopathy? It is a paradoxical state. It is a paradoxical condition where there will be increased bleeding and increased clotting, and it will lead to platelet depletion. It will be leading to platelet depletion or the clotting factor depletion. That is disseminated intravascular coagulopathy, which means because of the rupture of small vessels in the multiple sites, the patient will be having increased amount of bleeding. This increased bleeding is going to recruit more number of clotting factors. At last, what happened? Because of the multiple vasculature damage, multiple bleeding sites, what will happen? The patient is going to have clotting factor deficiency. So that is termed as your disseminated intravascular coagulopathy. So next, the lab findings, a very, very important test. So positive Coombs test. The patient will be having acute hemolytic reaction, transfusion reactions the patient will be having positive direct Coombs test. And because of the hemolysis, he will be having increased lactic dehydrogenase. Because of the lysis of RBC, he is going to have increased LDH, that is lactic dehydrogenase, and he is also going to have increased indirect bilirubin. Okay, is also going to have increased indirect bilirubin. Next, acute hemolytic transfusion reaction treatment. Immediate cessation of the transfusion, aggressive IV fluids administered, and you are going to give supportive care to that particular patient. So what is the complications of acute hemolytic transfusion reaction? If there is a question, you have to go and take acute renal failure and disseminated intravascular coagulopathy. Okay. So next we are going for febrile non-hemolytic reaction, which means if the term is clear, it is a non-hemolytic, which means there is no lysis of RBC. There is no lysis of RBC. It is the most common type of blood transfusion reaction. If febrile non-hemolytic reaction is the most common type of blood transfusion reaction. The onset is within 1 to 6 hours. Kindly note, the onset is within 1 to 6 hours. The cause of this reaction is cytokine accumulation. Very, very important point to note is, first and foremost, this particular febrile non-hemolytic reaction is the most common form of blood transfusion related reaction. And the next point is the onset of this blood transfusion reaction, febrile non-hemolytic reaction. The onset is 1 to 6 hours. What is the cause? If they are asking about the cause, you have to think about cytokines. When the cytokines is generated, when the RBC is having leukocytes, sedimentations of leukocytes. So in that case, this donor's leukocytes will be releasing cytokines, thereby there will be reactions between the donor's blood and the recipient's blood. So it is very important to note what is the cause of febrile non-hemolytic reaction. The cause of febrile non-hemolytic reaction is cytokines because of the donor's leukocyte, right? So the most important thing you have to notice, so what we can do if the patient is having the reaction because of cytokines, because of the leukocyte, you can go for leukoreduction. You can go for leukoreduction, which is one of the most important point you have to note. So in which of the cases leukoreduction, to prevent which complication, to prevent which blood transfusion complication, you have to do leukoreduction. You have to close your eyes and you have to go and take febrile non-hemolytic reaction. In case of febrile, to reduce the risk of febrile non-hemolytic reactions, you are going to do leukoreduction to the blood. You are going to do leukoreduction to the blood, so that what you will do, you will be separating the PRBC and the leukocytes, and you're going to only administer this what? PRBC to the patient. And we also have leukoreducing filters. Okay, leukoreducing filters. So that also can be used in this transfusion in order to reduce the risk of febrile non-hemolytic reaction. Important point you have to remember, first and foremost, it is cytokine mediated immune reaction. That is your febrile non-hemolytic reaction. And what is the onset? Its onset is 1 to 6 hours. That you have to remember. Next, the clinical features, the patient will be having fevers and chills because there is a leukocytic reaction, WBC reaction which is happening. So obviously the patient is going to have the fever and chills. So febrile non-hemolytic reaction treatment, you have to stop the transfusion and rule out whether it is acute hemolytic reaction or it is a febrile non-hemolytic reaction, because it is mimicking. The clinical feature is mimicking. Okay, and you're going to administer antipyretic because the WBC reaction is happening. Obviously, the patient is going to have pyrexia. Alright, so febrile non-hemolytic reaction prevention is done by leukoreduction. As I said you, it includes saline washing and freezing and deglycerolizing or buffy coat removal. Deglycerolizing, like you have to remove the buffy coat. What is buffy coat? I said the leukocyte sedimentation in between the PRBC and the plasma is termed as the buffy coat. So that is the leukocyte. So here you are going to remove that leukocyte, remove that buffy coat by doing a leukoreduction. It reduces the number of transfused leukocytes, so that it reduces the risk of this febrile non-hemolytic reaction which is happening because of HLA alloimmunization. Okay, and this leukocyte, by reducing, one more MCQ point which you have to notice, one more MCQ. Sorry, the color is not compatible. One more MCQ you have to note in this area is, like, by doing leukoreduction, I'm not only reducing this febrile non-hemolytic reaction, but also I'm reducing the risk of cytomegalovirus. Also, I'm reducing the risk of cytomegalovirus. So remember, I'm not only reducing the complications of blood transfusion, which is the febrile non-hemolytic reaction. By doing leukoreduction, I'm reducing the risk of cytomegalovirus. I'm reducing the risk of cytomegalovirus. So next is delayed hemolytic transfusion reaction. So first and foremost, you have to remember, in delayed hemolytic transfusion reaction, the causes is amnestic antibody response against the minor RBC antigen that leads to delayed mild hemolysis within 2 to 10 days. So delayed hemolytic transfusion reaction, the occurrence will be in 2 to 10 days. The occurrence will be in 2 to 10 days. The occurrence will be in 2 to 10 days. Okay, 2 to 10 days. So after transfusion. So here this is very common in case of sickle cell patients also. Sickle cell anemia patients will be exhibiting this delayed hemolytic transfusion reaction. Okay. So the sickle cell patients are at the higher risk of getting this delayed hemolytic transfusion reaction, and due to repeated transfusions, this patient are at the higher risk, which happens after 20 to 30 days. Sorry, 2 to 10 days. So the experience of sickle cell related intravascular hemolysis and the DHR related extravascular hemolysis is very common in these patients, right? So next, the clinical manifestation is the onset is less than 24 hours to a month after transfusion. Okay, it may be greater than 24 hours. It may be greater than 24 hours to a month after transfusion. Even after month, this delayed hemolytic transfusion reaction can happen. So you have to watch for these keywords such as delayed transfusion, how and all it is happening. Right, so it is often asymptomatic initially because it is very delayed. So next, the patient is going to have fatigue, dyspnea and tachycardia, and the patient will be having jaundice, low grade fever, lab findings. So the same lab findings which you find for hemolytic transfusion reaction will be here. That is, the patient will be going for hemolytic anemia, increased indirect bilirubin, increased lactic dehydrogenase, and increased reticulocyte count, and decreased hemoglobin and hepatoglobin. Okay, decreased hemoglobin and hepatoglobin, and new positive direct antiglobin, direct antiglobin, which is positive in the Coombs test. The treatment, the supportive care, delayed hemolytic, like it is same like you have to give the supportive care to the patient, you have to give more fluids to the patient. And delayed hemolytic transfusion prevention, how to prevent it? To receive the transfusion history and period antibody screening of the patient is very, very important. So here where the history collection is also playing a very important role. Okay, transfuse when necessary with extended antigen cross-matched blood. You have to do an extended antigen cross-matching so that you will be having, the patient will be in the safe hands. Right. So next, transfusion related acute lung injury. So here only I said the most common questions are coming from this point of right, most like MCQ point. This is the MCQ point. The color is looking so weird, right? Yes, we will change it to pen. Okay, so first is TRALI. The TRALI expansion you have to remember. Transfusion related acute lung injury. TRALI, transfusion related acute lung injury is TRALI. Okay, TRALI, you just remember your TRALI, that is transfusion related acute lung injury. So the causes of TRALI is due to transfusion of donor anti-leukocyte antibody. Okay, this is because of the anti-leukocyte antibody. This is because of the anti-leukocyte antibodies. And this onset is within 6 hours. Remember, the cause is anti-leukocyte antibody and the onset is within 6 hours. So the clinical features to differentiate between TRALI and TACO is very important. First, we will have a quick review on TRALI, then we will go to TACO. Okay, so the clinical feature or respiratory distress. The ultimate TRALI is, if you see the feature, transfusion related acute lung injury, this particular thing will produce the clinical, like mimic the clinical features of ARDS. It mimic the clinic features of ARDS. That is your acute respiratory distress syndrome. So the patient will be having respiratory distress and non-cardiogenic pulmonary edema. Very, very important point. This particular pulmonary edema which is happening, it is not cardiology centered. Okay, the patient will be having non-cardiogenic pulmonary edema with bilateral pulmonary infiltrations. So TRALI, remember, the patient will be mimicking the symptoms of ARDS. The patient will be mimicking the symptoms of acute respiratory distress syndrome, and the patient will be having severe respiratory distress, followed by he will be having a non-cardiogenic pulmonary edema, which is not cardiogenic oriented. Right, and he will be having bilateral infiltrates. So what is the management? Immediate transfusion cessation. You have to stop respiratory support care because the patient is going for respiratory distress. So obviously you have to give the respiratory supportive care, and say some patient recover within 24 to 48 hours. So next is transfusion associated circulatory overload. Question point. TACO. Before we see TRALI, that is transfusion related acute lung injury. This is TACO. TACO is transfusion associated circulatory overload. The volume overload. Here this is happening because of excessive amount of transfusion. When you're going to transfuse more amount of blood to the patient is going to have this TACO because of the volume overload. So what is happening? You have to remember TACO. TACO is because of volume overload. there is an excessive volume overload to the heart, and the heart is burdened, and it is going to cause this particular reaction because of the volume overload. Okay, the volume overload secondary to the transfusion of the blood products, this TACO will happen most commonly in case of massive blood transfusion. This is going to happen in case of massive blood transfusion. So the onset is usually within first 6 hours. The TACO and TRALI, they have similar kind of reaction durations. Okay, so you have to remember that is because of the anti-leukocytes, and this is because of the volume overload. That is because of anti-leukocytes, and this is because of the volume overload. So what are the features you will be having? Just remember, acute like respiratory distress, patient will be going for dyspnea specifically, and the patient will be going for pulmonary edema, which is cardiogenic pulmonary edema. Cardiogenic pulmonary edema. Patient will be having cardiogenic pulmonary edema, increased in heart rate, very important to note, increased in blood pressure. This is one of the classical feature which is going to differentiate between your TRALI and TACO. In case of transfusion related acute lung injury, the patient's blood pressure is going to be normal. The patient's blood pressure is going to be normal. But in case of your transfusion associated circulatory overload, because of the excessive workload to the heart, your BP is going to increase. Your BP is going to increase. Your blood pressure is going to increase. And as you all know, when there is a cardiac overload, obviously the venous distension will be there. You can see the JVD. JVD is also the again differentiating factor between TACO and TRALI. Next, the chest X-ray shows diffuse bilateral infiltrates. Right? The classical feature you have to remember is the BNP, which we will discuss in further. Like you have to remember the BP will be higher in case of your TACO, but it will be normal to lower in case of your TRALI. And what about the jugular venous distension? The jugular venous distension is going to be increased in case of your transfusion associated circulatory overload, TACO. Right? So what is the management? Respiratory support, again we are going to give diuresis. When they are talking about diuresis, furosemide and all, you have to remember that somewhere they are talking about TACO. When they are talking, the question is talking about blood transfusion, administration of diuresis. So like that, if the scenario is going, so you have to think about TACO. Right? When the BP, again if they are telling the BP is normal, and the patient is having bilateral infiltrates, and the patient is having the symptoms of acute respiratory distress, so then you're going to think about TRALI. Right? So these are the classical features between TACO and TRALI, which is very important. So blood pressure is lower to normal in case of your TRALI, but it is always high in case of TACO because of the circulatory overload. The body temperature normal to elevated, but here it is normal. So here the leukocytic reaction is there, that in course is going to cause fever. That in course is going to cause fever, but here there is no such leukocytic anti-leukocytic reaction. It is because of the volume overload purely. So what is going to happen? The patient is having increased blood pressure and the normal temperature. The chest X-ray is going to show bilateral infiltrates without vascular congestion. Here vascular congestion and pleural effusion is seen. Vascular congestion and pleural effusion. Why vascular congestion? Because of the excessive overload towards the heart, and there is a volume overload which in turn going to cause vascular congestion and pleural effusion. So brain natriuretic peptide, BNP, that is your brain natriuretic peptide. This particular component, this particular enzyme is presented in your ventricles. This particular enzyme is presented, I will write here, this is present inside the ventricles. So this, when there is an overload or increased stretch, increased pressure, this BNP is going to increase. So the BNP, normal value of this BNP, the normal value should be less than 100 pg per ml. Okay, less than 100 pg per ml. But you have to remember, in case of TRALI, it is going to be low, which is going to be less than 250 pg per ml. But in case of your TACO, it is going to be increased more than 250. In case of your TACO, it is going to increase more than 50. Because I said you BNP is the one which is involved in, BNP is the one which is involved in what? BNP is the one which is involved in ventricles, ventricle enzyme, when the ventricle is getting disturbed or the ventricle is getting more stretched or more workloaded, in that cases BNP is released. So normal value of BNP is 100. So in TACO only there is more amount of blood which is pooled inside the heart, which in turn causing what? Stretching of the ventricles, which in turn causing you the increase in the level of BNP more than 250 in case of your TACO. Please remember in that in mind. So pulmonary artery occlusion is low to normal, but here high. The pulmonary artery occlusion is also high in case of your TACO because of the compression. Next is ejection fraction will be normal in case of TRALI because it is limited to the lungs, but here in case of TACO it is often abnormal. Okay. Okay. See, BNP is an enzyme which is in the ventricles. It is not in the brain. Okay, dear? Okay. So, response to diuretics, inconsistent or no improvement. Here, there will be marked improvement because here we are having volume overload. So, once you are going to give diuresis, there will be no more amount of urine output and the volume is going to reduce and the patient is going to be feeling good. Right. Types of pulmonary edema, it is non-cardiogenic and it is cardiogenic specific. What is the causes? Immune mediated donor anti-leukocytic antibody reaction here because of the volume overload. So this table, I think it is very classical for you to remember the difference between TACO and TRALI. Just remember about important components. The BP is going to be normal in TRALI and it is going to be increased in TACO. The BP is going to be normal in TRALI and it is going to be increased in TACO. I request all the students to stay because you will be having the MCQ discussion. So it is very important to remember these concepts so goodly. Okay. And the primary treatment supportive, as we discussed earlier, stop the transfusion and give the diuretics as we discussed earlier. The things which you have to remember is BP. First is it is high in TACO, it is normal to low in case of your TRALI. Next is the body temperature, it is elevated because it is the anti-leukocytic reaction of the donor antibody. So that is why it is going to increase. Here it is normal. And in BNP it is going to be low only, but in case here it is high. So your PaOP is going to low to be normal and it is high here. Right, ejection fraction is normal and here it is often abnormal. So that is the thing you have to remember. Now transfusion transmitted bacterial infection, as I said you, the most common involved is your bacterial. The most common thing which is involved is your bacterial reaction or bacterial contamination is most common in the platelet transfusion, as I said you. Here it is written. Okay, it is written, it is mostly related to the platelet transfusion, as I discussed earlier. So what are the components? So what is the most common organism? What is the most common organism? Just remember very, very important point. It is your Yersinia enterocolitica. It is your Yersinia enterocolitica. The most common pathogen which is transmitted because of the bacterial contamination in your blood transfusion is your Yersinia enterocolitica. Remember this, the most common pathogen, it is a gram-negative bacteria, that is your Yersinia enterocolitica. It is a gram-negative organism. So what is the clinical feature? Obviously, because of the infection, the patient is going to have fever which is greater than 39 degrees Celsius, chills, patient will be going for septic shock, DIC and hypotension. The management is done by obtaining the culture. First you are going to obtain the culture and based upon it sensitivity, you are going to analyze and start your antibiotic treatment. So graft versus host reaction is the last and next we are going to discuss about MCQs. Please. Okay. So it is mainly caused due to donor T lymphocytes. Graft versus host reaction, the cause is donor T lymphocytes. And what is the onset? Within a week. The onset is within a week. And the clinical feature is rash, fever, gastrointestinal symptoms and pancytopenia. Now it's time to stay active. Okay, we have one more topic which is very important again. That is your massive blood transfusion. What is massive blood transfusion? This was an MCQ, right? So first remember what is massive blood transfusion. As the name implies, it is massive, which means it is very big. We are going to transfuse large number of blood. So here, replacement of the entire circulatory blood volume within 24 hours. Replacement of the entire circulatory blood volume within 24 hours is the one definition. Next is transfusing more than 10 units of PRBC within 24 hours. Transfusing more than 10 units of PRBC within 24 hours. Next, more than 4 units of blood transfused in 1 hour. Even if you're telling, it is not only I am transfusing more than 10 units of blood, 10 units of PRBC within 24 hours. If I am transfusing more than 4 units in just 1 hour period of time, that is also termed as your massive blood transfusion with ongoing transfusion need anticipated. So this is all the definition of massive blood transfusion. If you see any of this following key points, like replacement of the entire circulatory blood volume within 24 hours is also the massive blood transfusion. If you are going to administer more than 10 units of PRBC within 24 hours of time period, that is also termed as your massive blood transfusion. If you are going to administer more than 4 units of blood, 4 units of bag within 1 hour period of time, that is also coming under your massive blood transfusion. So next you can see what is the complication. First is coagulopathy. Coagulopathy means bleeding reactions. Okay, this is minimized when there is a pressurized rapid transfusion within a with a line warmer. First and foremost complication of massive blood transfusion is coagulopathy, keep in mind. But if they are going to talk about increased in BP, other than bleeding, if after massive blood transfusion, if they are going to talk about respiratory distress, BNP, okay, talking about the acute like lung injuries and lung infiltrates, then you have to think about TACO on TRALI rather than coagulopathy, right? So next is TRALI, that is transfusion related acute lung injury, respiratory distress, non-cardiogenic pulmonary edema, plus BP is normal and BNP is also normal, which is less than 250 pg per ml. Next is TACO. TACO is transfusion associated circulatory overload, as we have discussed earlier, and the respiratory distress will be there, and here you will be having a cardiogenic pulmonary edema, and you will be having increased in BP, very important, very important, increased in BNP increased in BNP which is greater than 250, pg per ml. Okay, pg per ml. So next the patient will be having hyperkalemia. Why hyperkalemia? We have discussed in the earlier cases, because of the lysis of the RBC which is stored in the low temperature, which is near expiry date. In this case, this will causes hyperkalemia. This hyperkalemia will further is going to lead to diastolic arrest and bradycardia. Which kind of arrest is common in case of the massive transfusion? Systolic arrest, diastolic arrest, then you have to go on take diastolic arrest. Okay. So next is hypocalcemia. What is meant by hypocalcemia? See, children who are not understanding, you have to watch the session from the beginning so that you will be getting a clarity. If you watch in between, you cannot understand anything. Okay, you have to watch it from the beginning. Okay, you have to watch it from the beginning. Okay, next the patient is going to get hypocalcemia. I said you, what is the reason for hypocalcemia? Because of the citrate. It is going to chelate to calcium. It is going to chelate to calcium, which is going to lead to hypocalcemia. So if the patient is expressing twitching and twisting light of symptoms, in that cases also you have to think about hypocalcemia. Hypocalcemia will again lead to laryngospasm. Hypocalcemia is going to again lead to laryngospasm, and difficulty in breathing and stridor is also possible when the patient is going for hypocalcemia. Hypocalcemia, why it is happening? As the previous students who have listened the class from the beginning, now tell me, what is the reason for hypocalcemia? It is because of the what? Hypocalcemia is because of the citrate toxicity, because of the chelation of the calcium. This is leading to the hypocalcemia. So now coming back to the questions, very important part. Now you people are going to answer me actively. The first question. A 65 years old female with anemia receives 3 units of packed RBC. A 65 years old female with anemia receives 3 units of packed RBC. 2 hours later, she developed acute dyspnea. 2 hours later, she develops acute dyspnea. Two hours later, she developed acute dyspnea, hypoxia, and bilateral pulmonary infiltrates on the chest X-ray. Her JVP is normal. Key point, you have to note, her JVP is normal. Please, you have to think so detailedly and you have to answer me. Okay? Chess, I'm just waiting for the answers for many people. Her JVP is normal. BNP is 150 Pg per ml and she remains hypotensive despite oxygen therapy. What is the most likely diagnosis? Children? Yes. Very good. Ankita. Very good, Priya. Very good, Debashish. Yes, your name is Debashish. I will call you Palai. That is easy, right? Sorry, Ankita, no. The answer is a transfusion related acute lung injury. The answer is B. Debisha, Palai and Priya. Very good. See, Sasmita, like why you people are answering A? If you see transfusion associated circulatory overload, as I said you children, in case of transfusion associated circulatory overload, in this case, the patient is going to have increased BNP. As I said you, the BNP level is going to be greater than 250 Pg per ml. Okay, the BNP level is going to increase and the patient is going to have increased BP. The patient is going to have increased BP in case of TACO. So, how you can tell the patient is having TACO? No. Just remember, yes, very good Priya, very good. So, remember, the most important classical feature you have to understand is acute dyspnea, hypoxia, bilateral chest pulmonary infiltrates are very common in case of both TACO and TRALI. But what is the differentiating factor? I taught you about the blood pressure. The blood pressure is going to be increased in case of your what? TACO, because of the circulatory overload. And the BNP, brain natriuretic peptide, is also going to be increased in case of your TACO. Why? Because the ventricles are stretching so much so that this enzyme is released. And we are analyzing it. Right, it should be less than 100, that is normal. So in this case, when the patient is going to TACO or TRALI, it is going to be more than 250. So again, the JVP is normal. It is TRALI, it is not TACO. When in case of the JVP is going to, the JVP is going to rise in case of TACO. It is not going to decrease, right? The JVP is going to rise in case there is more amount of circulatory overload. The JVP is going to rise. It is not going to decrease. And it is clearly telling the patient is having pulmonary infiltrates, acute dyspnea, hypoxia, bilateral pulmonary infiltrates, but the JVP is normal. They are putting a word. There is a JVP is normal and the BNP is also normal. Okay, the criteria for us is more than 250 if the patient is going for TACO. But here if you see the BNP, it is 150. Don't confuse yourself. Like that only they will be confusing, giving you the values of BNP, JVP to add them as a keywords and confuse you between TACO and TRALI. But you should be very clear with the concepts. I hope that is clear to everyone. What is the difference, basic difference between TACO and TRALI? Is it clear or I want to repeat it once more? You can tell me in the comment box. Obviously, anaphylactic reactions, febrile non-hemolytic reaction is not going to have any kind of pulmonary infiltrates and dyspnea and hypoxia, right? So obviously the answer is TRALI. The correct answer is transfusion related acute lung injury. Is that clear? Shall we go to the next question? Yes. So now, the next question, just get ready with your answers. I'm waiting eagerly. A patient undergoing emergency surgery receives 12 units of PRBC in 24 hours. So what is the definition? You can have a correlation. The patients undergoing emergency surgery receives 12 units of PRBC over 24 hours, and shortly after he developed muscle twitching and laryngospasm. Now only we have studied it. It is very, very easy MCQ. ECG shows prolonged QT, other interaction with the other cardiovascular system also. ECG is showing prolonged QT. Which lab finding is most expected? Now tell me. The ECG is showing prolonged QT and the patient is having muscle twitching, and the answer is hypocalcemia. It is a very, 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 very easy answer. It is a very, 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 very easy answer. So the patient is developing laryngospasm. As I said you, muscle twitching and muscle twisting is happening in case because of the citrate chelation towards the calcium. So what happened? The citrate is going to absorb more amount of calcium from the blood when it is the PRBC is stored and transfused. So what happened? The citrate which is present in the packed RBC, what it is going to go? It is going to chelate the calcium which is present in the recipient blood also. So this in turn going to cause what? This in turn is going to cause hypocalcemia. This hypocalcemia will lead to laryngospasm. So that is how the answer is hypocalcemia. Crystal clear? Crystal clear? Just tell me crystal clear if you are clear in this concept, and you can able to definitely differentiate TACO and TRALI, because very, very, very important to your examination. So next, hyperkalemia is seen in which condition? I'm just waiting for the answer. Hyperkalemia is seen in which condition? When there is a lysis of RBC, because RBC loves to keep potassium inside it. So when there is a lysis of RBC, because of the breakdown of the RBC, all the potassium is going to release outside. That in turn, you're going to see hyperkalemia. And hypercalcemia is nowhere having the interaction with blood transfusion, and metabolic acidosis is also not. So because of the chelation of citrate and calcium, and citrate is metabolized in the liver only. Okay, citrate, very good, very good, very good, very good, very good. So metabolic acidosis is metabolic alkalosis happens because of the metabolism is happening. The citrate is metabolized in the liver. So that's why metabolic alkalosis is needed, right? And the patient will go for hypocalcemia. Metabolic acidosis is not having any interaction. Very good. No. Do and 2B is not the correct answer. Okay, B is not the correct answer. C is the correct answer. Just remember, whenever the patient is going for any muscular twitching or laryngospasm, and they have given an additional keyword, that is prolonged QT. So obviously the answer is hypocalcemia, right? We will go to the next question. Be active like this. Okay, now you are going to tell me the answer. A patient on massive transfusion protocol develops bleeding from IV site and mucous membrane. She is developing bleeding from the IV site and mucous membrane. Lab report shows the patient is having thrombocytopenia and prolonged PT. Prolonged PT means it's a prolonged prothrombin time. What is most likely the cause? What is most likely the cause? Now tell me the answer. Like, just correlate in which cases you will be having mucous membrane bleeding, site bleeding, at the IV site bleeding, and already it is given the patient is going for massive transfusion protocol. Already the patient is going for massive transfusion. Now tell me what is the answer. Very, very good. Please give a big round of applause to yourself, my dear children. Kushal, Manush, Kushal, Muva, Dibesh, Pali, Dharmaraj, Prativa, Ritvik, very good, very good. I am just giving a hats off to you people. Dilutional coagulopathy is the correct answer. Remember, there is no signs and symptoms which is relating to TRALI and TACO and anaphylaxis. There is no signs of itching or something like that which is relating to these particular symptoms. There is no relation of heart rate or BP, BNP, JVP, nothing. Respiratory related issues, nothing. But they are telling specifically there is a bleeding in the IV sites and the mucous membrane, and there is a prolonged PT, and the patient is having thrombocytopenia. So the patient is going for dilutional coagulopathy. With the same enthu, we are going to the next question. Yes. Now, get ready for the next question. A patient develops fever, chills for 3 hours into RBC transfusion. Vitals are stable and there is no respiratory distress or hypotension. Which intervention could have prevented this reaction? The patient is developing fever and chills within 3 hours into the RBC transfusion. Vitals are stable and there is no respiratory distress. Now tell me, or hypotension, which intervention could have been prevented this reaction? Waiting for your answers with a very enthusiastic way. Very good, very good, very good, very good, very good. Batin Pash. Nadia, very good, very good, very good, very good. Dharmaraj, very good, very good, very good, very good. So now tell me, what is the diagnosis of the condition? You have answered leukoreduction for donor blood. So what is the diagnosis? The question implies what transfusion reaction? The question implies what transfusion reaction? Now tell me. You know leukoreduction is very, very specific to one kind of transfusion reaction. Now tell me what is the transfusion reaction? Very good. Dharmaraj, Muva, Dibash, Aarti, Panwar, very good. You have answered correctly. Leukocyte reduction for donor blood. Now tell me, what is the transfusion reaction which is given in the question so that you selected C, leukoreduction for donor? Answers, answers. Very good, very good, very good. Please give a big round of applause to Nadia and Batipa and Dibash. Very good, very good, very good, very good. Ritvik, very good, very good, very good. So you people are going inside NORCET this time definitely, if you are going in the same track. So listen, the patient is a case of febrile non-hemolytic transfusion reaction. So as I said you, the most important prevention strategy for febrile non-hemolytic transfusion reaction is usage of leukoreduction. Usage of leukoreduction of the donor blood, so that what happens, the cytokine reactions will not happen in the donor, in the recipient case. So that's why this is the correct answer. Very good, very good, very good. So now let's go to the next question. During the first 15 minutes of transfusion, a patient reports chills, flank pain and dark urine. The patient reports chills, flank pain and dark urine. It is within 15 minutes. Vital shows hypotension and tachycardia. What should the nurse first do? Answer. Very good, very good, very good. Very fast. Priya is very fast. Very good. You have to stop the transfusion and start the NS. And we are going to analyze whether it is any kind of whether it is related to any kind of immune mediated reactions or not. So to analyze that, you have to stop the transfusion and start the NS. Okay? Slow the transfusion and notify the physician. Never ever slow the transfusion if there is a reaction. Very, very important high priority points when you are going for the examination. Administer acetaminophen, no. Check the blood pressure again in 30 minutes, no. They have not given blood pressure at all. Why we want to check? So very good. Okay, always stop or cessation of the blood transfusion. Yes, very good. Option C is always correct. Yes, very good. Very good. Anu, Ankita, Nadia, Dharmaraju, Priya, Aarti, Shashmita, Muva. Very good, very good, very good, very good. Okay, so now next question. A 72 years old patient develops dyspnea. Okay, develops dyspnea, raised JVP and bilateral basal crepitizations for 1 hour into the transfusion. What is the nurse's immediate action? Most appropriate immediate action? Yes. So now you have to give me the correct answer along with what is the rationale. Now you have to give me what is the correct answer along with the rationale. Like a 72 years old patient develops dyspnea, raised jugular venous pressure and bilateral basal crepitization for 1 hour into the transfusion. What is the nurse most appropriate immediate action? Very good. Stop the transfusion and administer prescribed diuretics. Now tell me why you selected this as the correct answer. What is the diagnosis from the question? What is the diagnosis from the question? Very good, Dharmaraju. It is volume overload. It is volume overload. So what is mean by volume overload? What is the condition? It is TACO. Transfusion related. Okay. It is your TACO. Transfusion associated circulatory overload. Okay. Transfusion associated circulatory overload. Very good, very good, very good. Furosemide to prevent TACO. Very good, very good, very good. Shabana. Very good. Ankita. Very good, very good. No, it is not TRALI, Ankita. It is TACO, dear. It is not TRALI. It is TACO. Remember? See here, the patient is having raised GVP. The one classical finding which is differentiating in the question between TRALI and TACO. TACO is a cardiac overload of volume, which is going to cause your jugular venous distension. The patient's blood pressure is going to increase. The BNP level is going to increase. But in case of TRALI, what is going to happen? The BP is going to be in the normal level, but the patient will be having fever in case of TRALI. Dyspnea is very common in both the cases. What about the BP? It is normal to low in case of your TRALI, but in TACO it is going to be increased. What about the JVP in TRALI? The JVP in TRALI is normal. It is not increased. But in TACO, it is increased. Please remember these things. Very, very important point. TACO is the correct answer. If you think TRALI, just throw it out from your mind. TACO is the correct answer. Okay. So you have to prescribe diuretics. You will be prescribing diuretics as per the physician order only if the patient is a case of TACO. And I have also instructed you, diuretics will have some reaction in TACO, but in TRALI, no effect. Okay. Next. Now tell me, during a massive transfusion in an emergency surgery, what should the nurse do to prevent transfusion induced hypothermia? Very easy question. Immediate answers I need. During a massive transfusion in an emergency surgery, what should a nurse do to prevent the transfusion induced hypothermia? As you all know, the PRBCs, everything and all the components when they are transfused, which will cause hypothermia. So how to reduce this hypothermia? I want the correct answer. Yes. Yes, Anu, Priya and Shabana, you people are correct. Yes. No. Before administration, you have to use the blood warmer during the transfusion so that you can reduce the risk of hypothermia to the patient. Better to use warmer. That is the most important correct answer also. Increase the room temperature? No. Wrong answer. Administer antipyretics prophylactically. You should not administer any pre-medications before giving the transfusion. Next, keep the blood products at the room temperature before transfusion. No. There is always limitation within how much time you have to transfuse once the product is received from the blood bank. So, A is the correct answer. So, a patient develops fever and chills 1.5 hours into transfusion, but has no hypotension or respiratory symptom. What is the nurse most appropriate action? The patient develops fever and chills 1.5 hours into transfusion, but has no hypotension or respiratory symptom. What is the nurse most appropriate action? Very good, Ritvik. Very good. Your rationals are very good. Now answer for the question number 8. A patient is developing fever and chills 1.5 hours into the transfusion. There is no hypotension, no respiratory symptoms. What is the nurse most appropriate? B. C is the correct answer. Very good, very good, very good. Those who have answered C. Stop the transfusion, notify the physician and send the blood back for testing. See here, when the patient is having the fever and chills within 1.5 hours of administration of the blood, the patient will be, either he will be having hemolytic reactions or non-immune mediated reactions also. So first you have to resend and re-verify and do the cross-matching and all again. So that's why you have to stop the transfusion and notify the physician and send the blood back immediately for the testing. You should not confuse yourself here. Only stop transfusion word is there, but discard the remaining blood. You don't have any authority to discard the remaining blood. You have to do the cross verification and identify what is the reason for this reaction, and then only you have to proceed, right? So obviously C is the correct answer. Now tell me, what is the primary purpose of the device shown in the image? Is the image is clear? Now I need your answer. What is the primary purpose of the image shown in the device? What is the device indicating? What is the primary purpose? Yes, I'm waiting for your answers. I'm waiting for your answers. Very good, very good, very good, very good. This is the leucofilter, okay, which is used in order to prevent the leukocytes entry during the times of transfusion. So obviously you know leukoreduction, in what case we do? In order to reduce the febrile non-hemolytic reaction only we use leukoreduction. Okay, so this is the image of the leukoreducers. Image is not clear. See, if the image is not clear, leukocyte reduction filter, you just put in the Google and see the image, and there is a lot of possible chance you will get image based questions in this particular image. This is the leukofilter, okay, leukocyte reducing filter. So obviously leukoreduction, in what case we are doing leukoreduction? Obviously we are doing leukoreduction in order to reduce the risk of febrile non-hemolytic transfusion reaction. Okay. Next question. A patient develops fever, chills and hypotension during platelet transfusion. During platelet transfusion, keyword, fever, chills and hypotension. The transfusion is immediately stopped and the blood culture are sent. What is the most likely causative organism responsible for bacterial contamination stored blood product? What is the most common pathogen which is involved in bacterial contamination? Very good, Priya, very good, Priya, Nadia, Muva, Sumant, Shashmita, Dharmaraj, Ankita, very good. Yersinia enterocolitica is the most common organism which is going to cause bacterial contamination in stored blood, as I said you earlier. So just remember the important organism is your Yersinia enterocolitica. Now we will have a brainstorming. Now tell me, what is the device which you see in the screen? Now tell me, what is the device you see in the screen? What is the device you see in the screen? Yes, I'm waiting for your answer. What is the name of this device? Anyone? Blood warmer? No, dear children, no, it is not a blood warmer. What is this device? The beautiful device. Tell me. The name of this device is rapid infuser. Okay. So in case of massive transfusions and all, this particular device is used, okay, which is going to create a pressurized transfusion system a proper transfusion system in case of massive transfusion. So this is a rapid infuser which is used in the blood transfusion stand. What is this answers? It is not blood transfusion stand. It is the rapid infuser. Okay, it is a rapid infuser which is used in the massive blood transfusions. Okay, okay, very good. So this is all about the class for today. This is all about the class for today, and I thank each and every students who were with me from the beginning to the end of the session. Okay, I thank you all so much. Okay, for being with me all over the class. It's very good and it is very pleasureful for me, and I hope that I have given a very good insight about blood transfusion and transfusion related complications. And students who are angry on me for not talking in Hindi, मुझे थोड़ा थोड़ा हिंदी आती है, मुझे ज़्यादा हिंदी नहीं आती है. So I will learn soon and to be with you on track. And I just want you people to put your reviews under the video so that I can do I can improve myself, or in which areas I need and the additional things I can make that particular changes also. Right? And this is my Instagram handle, and have any scientific queries related to any condition like pharmacology, OBG, adult health nursing, you can contact me at any time. Next class I will be coming on every Friday. I'm going to come live. So every Friday you can connect with me. Okay, dear children, and please share your valuable feedback so that I can see to it and I can feel happy also. So thank you so much for all the students, and all the very best for all your upcoming examination. Thank you so much.